Hello guys, welcome to the case scenarios, and this is your second case where we will try to analyze the question and solve it and also learn the approach towards these questions. So let's get started. Here we have a 3-year-old girl, a small child, 3-year-old girl, brought to the physician for the intermittent eye crossing. The parents say that her left eye is intermittently turned in during the first few months of the life. Now, can you see, this explains clearly what I usually say, that these things are usually neglected in the early years of life. See, the parents had noticed her left eye turning in intermittently in the first few months of the life, and now she is 3-year-old and still no treatment has been given to her. Now the symptoms have returned in the past months and they are especially around the bedtime. Now what has this to do with the clinical symptoms? They are more towards the bedtime. So that means they are more in the dim light. We always have these two things, whether the symptoms are more in the daylight or whether the symptoms are more in the dim light. So these symptoms are more in the dim light. She has no headache or pain. Important negative history also has been provided. She is not giving you any headache or the pain. The girl was born full term, no medical conditions, and met all the developmental milestones. Now, by this the patient, important birth history is also being given, and this is important because whenever you are dealing with a child, when your patient is a child, we should have all the important birth history, whether she cried at birth or not, whether it was full term, whether it was preterm, any congenital malformations, any other positive history, or whether she attended the milestones on the time or not, because we want to know whether there is a developmental delay, whether there is a growth delay, because there are so many indications which are related to this. Now the vitals and the growth are also normal. So that was I was saying, because when the growth is not normal or there is a failure to thrive, there is a mental delay, there is a developmental delay, there are seizures or there are mental retardations, or the child is not crying at the right time, or the child was preterm, your horizon of thinking, the diagnosis will be becoming wide and wide. Now examination is showing a very important thing, that is the asymmetric corneal light reflection. What do you mean by this? I'll tell you. When the right eye is covered, left eye moves the midline. Vision screening is normal. So visual acuity is normal, but there is asymmetric corneal reflection. Now what do you mean by this? I will tell you. Suppose these are the eyes of this 3-year-old girl and these are the cornea. Now normally when you show the light, what is happening? You get the corneal reflex. We get a light reflex in the center. So this should be present in the center of the pupil in both the eyes. That is called as symmetrical corneal reflex test. Okay. On this basis, we do the Hirschberg corneal reflex test. So this test is based on this finding. It is also called as HCRT test, that normally these reflexes should be lying just in the center. Now suppose this is the right eye of the patient and this is the left eye of the patient. Now they are saying that it is actually showing asymmetrical corneal light reflection. And what is this asymmetry? In which eye there is a asymmetry? That is present in the left eye. Why? Because they said that the left eye is returning in during the first few months of the life. Now when they are covering the right eye, if I am covering the right eye, so that means I am covering the normal eye. If I am covering this right eye, that means I am covering the normal eye. So how can you cover it? We cover it with the help of a occluder. So it becomes something like this. We have occluder, and with the help of a occluder, we have covered this normal eye. So when I cover the normal eye, this test is called as, what is the name of this test? This test is called as the direct cover test. Then this test is called as the direct cover test. Now they are saying that the left eye is intermittently turning in. So what should I expect? If I cover the normal eye, this left eye becomes the only fixating eye. So if it was turning in, now where should it go? It should be going outward. So what it is doing now, because it was turned in, it was something like this. It was turned in. So now what is done, because you have covered the normal eye, we are expecting this eye to fixate, due to which it is now crossing the midline and it is coming something like this. Okay, so that means the left eye that was turning in was showing you the EZO. That was showing the EZO. EZO means the convergent squint. Now what we do in such cases, we are covering the other eye, which is the normal eye, and when you are covering this normal eye, the squint eye becomes the only fixating eye. So this eye was turned in. So when it wants to fixate, it will show a recovery movement in the opposite direction, and because of the palsy, obviously it cannot go up to that limit, so it is just crossing the midline. Visual acuity is normal. Rest of the examination is also normal in this eye. Rest of the examination is also normal. What is the most appropriate next step? Next step in the management of this patient. So you have to take care that they are not asking you the best step, they are asking you the next step. Now this is again a very important catch point in the question, because many a times the best step is also given in the options, and with the blind eyes we always go with that because you know that that is best. But you have to concentrate on the question also. They are not asking you the best, they are just asking you the next step, what you should do. So first I will try to analyze what is there in this eye. So this patient is having intermittent squint, yes, and that squint is a variety of manifest squint, because the patient attendant or the parents can see it, and what they are seeing that the intermittently this eye is going in. So intermittent convergent kind of squint is there. Now obviously when this eye is having intermittent convergent squint and you are covering the other eye, that means I am doing the direct cover test. Okay, don't get confused between the cover uncover test. Cover uncover test we do for the latent squint, where the squint is hidden. Okay, but here the squint is manifesting intermittently and the eye is going in. So the patient has the intermittent convergent squint. Now when I cover this normal eye, this eye, squint eye, becomes the only fixating eye. So when it is fixating, it will take a recovery movement, and that recovery movement will be in the opposite direction and it is crossing the midline. Are you getting it? So basically I am dealing it with a case of squint which is manifest and which is intermittent. Now on this basis I'll try to see the options what they have tried to given us. So first step is brain MRI. The first step is the brain MRI. Now am I supposed to just order the brain MRI without actually doing the physical examination, without analyzing the other things, straight away going for the brain MRI? No, it is not the next best step that you can go for, because always you have to first examine the patient, try to find out what is the palsy that is present in the patient. Like this patient is having the intermittent convergent squint, and you know mostly the convergent squint is due to the lateral rectus palsy. The most common palsy that you are getting as isolated nerve palsy is the sixth nerve palsy, and due to this sixth nerve palsy, what you are going to get? You are getting the palsy of the lateral rectus. Now always remember, important thing, that all three SO4 and LR6. This is a very important mnemonic that is going to help you in all the squint related questions and the nerve palsies, that all the extraocular muscles are supplied by the third cranial nerve except for SO4 and LR6. Now, whenever you have the isolated nerve palsy, it is the sixth nerve palsy that is most common, and sixth nerve supplies the lateral rectus, so you are going to get the lateral rectus palsy. Due to this lateral rectus palsy, this person is going to have the convergent squint, and due to this convergent squint, the recovery movement which is going to be present in the patient will be outward. This is very clear. So, if I am getting a patient who is having a convergent squint, I am having the lateral rectus palsy, obviously I will first try to do the examination, and only then afterwards I will go for the MRI to find out what is the real cause. The most common etiology that you get in the sixth nerve palsy is the raised intracranial pressure. What you are going to get is the raised intracranial pressure. So, we will be having any cause. It can be like trauma. They have not given you any history of trauma. It can be the tubercular meningitis, any infective foci. Again, they have not given you that. It can be any tumor. It can be any space occupying lesions. Moreover, the sixth nerve palsies are associated with the cavernous sinus thrombosis. Very important. It is also associated with the cavernous sinus thrombosis, superior orbital fissure syndrome, orbital apex syndrome. So, there are so many things, but obviously it is not evident here. Why? Because you know, these kind of syndromes are also associated with the other manifestations. If I have cavernous sinus thrombosis, I will have proptosis, I will have chemosis, I will have congestion, I will have mastoiditis, I will have acute febrile illness. So, I am not going to get it quietly. So, it appears that it is most probably a comitant kind of squint. It is most probably a comitant kind of a squint. Comitant squint means which is a non-paralytic variety of squint, where you know, the patient is actually having the equal amount of deviation in all the gazes. So, in cases of the comitant squint, if you remember, what is the treatment that we follow? The treatment regimen that we follow in cases of the intermittent squint, that is your comitant variety of the squint, we have to always follow a particular order. So, what is that order? That is C, O1, O2, S and P. You have to always follow this order, and this order is again important because they are asking you the next step. So, first is C, that is correction of the refractive error. You have to go with the correction of the refractive error. Then we have O1. O1 means the occlusion therapy. We have to go with the occlusion therapy. Then next O is the orthoptic exercises. Then we have got S. S means the surgery. You are going to do the surgery for the squint. And P for prisms that we are going to give for the remaining correction. So, in this order we have to go. We don't have to go direct for the brain MRI. So, this is not the next best step that you are going to do in a patient like this. Looking at the option number B, measurement of the intraocular pressure. Now, intraocular pressure means I am thinking about the congenital or the developmental glaucoma. Only then I am expected to do the intraocular pressure. Now, is the presentation of congenital glaucoma like this? No. What you are expecting to be present in the congenital glaucoma? So, if you remember, if the congenital glaucoma takes place less than 3 years of age, then it is called as the buphthalmos. Then this condition is called as buphthalmos, and this patient is going to present typically with the classic triad BPL triad, that is called as your below poverty line. So, this baby should have come up with the blepharospasm, that is the lid spasm, there should be photophobia, right? And then there should be the lacrimation. This is the typical triad that we are going to get in the patients of congenital glaucoma, right? This is your classical triad. Along with this, we should have the frosted glass appearance. We should have the frosted glass appearance, in which I will have the haziness in the cornea. Then I should have the megalocornea, increased size of the cornea. Then I should have the B for blue sclera. One of the important things is blue sclera. Then I will also have B for backward. B for backward subluxation of the lens. B for backward subluxation of the lens. So there are so many things that are confirmatory, that are suggestive of congenital glaucoma or the ophthalmos. So I am not going to get all these things in cases of the ophthalmos which are given in the question. The eye is turning in right there, and you know, when you are covering the normal eye, it is passing the midline. So certainly it is not a case of ophthalmos, and there is no point of taking the intraocular pressure. So this is also not the right option. Now coming to the option number C, patch on the right eye. So I'll come back to this. First, see the D option, watchful waiting. Will you wait? See, when you are having the convergent squint at the time of birth, or you are having in the early years of life, what are the things that you are going to think of? Like if I am having a convergent kind of a squint, I can think of the lateral rectus palsy. But I am not thinking about that, because you know, lateral rectus palsy, if it is a paralytic variety, it should be presenting with the other signs and symptoms of the raised ICT, proptosis, chemosis, cavernous sinus thrombosis. So here I am thinking either the comitant squint, either I am thinking of the comitant squint, which is the non-paralytic variety. One thing is this, or the second thing is that I can also think about the retinoblastoma, because in the retinoblastoma also the people will be presenting with the squint, and mostly this squint, most commonly this squint is the ESO squint. But now if the patient is having retinoblastoma, they should have also mentioned about the leukocoria, which is the most important sign. Along with this, squint is the second most common sign. So they have not given this. But even if the patient is having the comitant squint, or if we are suspecting about the retinoblastoma, there is no point of waiting, because if you are waiting, certainly this eye can go into the amblyopia, and once the amblyopic eye becomes refractory, you know, after the age of 5 to 6 years, after the age of 5 to 6 years, this eye becomes refractory and the patient is not able to get the vision even if you are treating it. So that can be uncorrected refractive error also. It can be high accommodative upon the accommodation ratio. You know about the comitant squint. When it comes to the comitant squint, when it comes to the comitant squint, what are the types of squint that I can have? So it can be ESO or it can be EXO. Now in the ESO, I can think about the accommodative squint, accommodative, or it can be non-accommodative, right? And when it comes to the accommodative squint, again I can have two, that is I can have refractive, I can have the refractive kind of accommodative squint, or I can have the non-refractive variety, non-refractive variety of the accommodative squint. So maybe this 3-year-old girl is having the refractive variety, she is having uncorrected refractive error, hypermetropia, or she may be having, you know, hypermetropia, or she can be having high AC upon A ratio. So visual acuity is affected, the patient can have amblyopia, and therefore it can become refractory. So what you are going to do for the amblyopia? Now check the options here, what you are going to do. for the amblyopia. So the best thing that we do for the amblyopia is the occlusion therapy. What is this occlusion therapy? Here actually you cover the normal eye. For the occlusion therapy, we cover the normal eye. Our aim is to stimulate the squint eye to see, so that it is forced to fix. So how can you do it? By covering the normal eye. Now obviously when you are covering the normal eye for a 24/7, now this eye can go into amblyopia. So always follow the rule of occlusion. Very, very important. Always follow the rule of occlusion. What is this rule of occlusion? This is x is to 1 according to the age in years. This applies to the rule of occlusion is your x is to 1 according to the age of the child in years. So at 1 year of age, we will follow 1 is to 1. At 2 years of the age, we will follow 2 is to 1. At 3 years of the age, we follow 3 is to 1. At 4 years of the age, we follow 4 is to 1. And at 5 years of the age, we follow 5 is to 1. Now I tell you what is the meaning of this. At 1 year of age, you are following 1 is to 1. So that means 1 is your x. That is your number of days of occlusion. Number of days of occlusion. So you are going to occlude this eye for 1 day, and then 1 is the day where you are keeping that normal eye open so that it does not go into the amblyopia. So what you are going to do at 1 year, you are following just 1 is to 1. That means number of days of occlusion will be equal to the number of years in age. Okay. So if the child is 1 year of age, you occlude for 1 eye, keep it open for 1 eye, then 1 day occlusion, then 1 day open, then 1 day occlusion and 1 day open. At 2 years of age, you will increase the number of days of occlusion to 2. So now you will follow 2 is to 1. So 2 day occlusion, 1 day open, 2 day occlusion and 1 day open. At 3 years of age, go with 3 is to 1. So now 3 day occlusion, 1 day open, 3 day occlusion, 1 day open. Similarly at 4 years of age, 4 is to 1, 4 day occlusion, 1 day open, 4 day occlusion and 1 day open. And then at 5 years of age, go with the 5 is to 1, 5 days occlusion, then 1 day open, 5 days occlusion and then 1 day open, and similarly we can do it. Now don't do it beyond 6 years, because you know 6 years ke baad the eye is becoming refractory, amblyopia becomes refractory and you do not have much of the benefit. So this is the way we are giving the occlusion therapy. That is very, very important. Now it is very easy to say, but it is very difficult to do it. Can you expect a 3-year-old child letting you allow the occlusion? It's very, very difficult. Now, first of all, wearing the spectacles and that too covering on one eye is really a tough job. So we make it interesting. We give them the colored patches, like pinks for the girls, blues for the boys, and whatever they are liking, the butterflies, the Disney princess, Doraemon, Shin Chan, whatever they are liking, we are applying those kind of patches so that they look attractive. You know, there are so many times siblings who are, you know, doing mischief with them. They are like making fun of them. That's why also they don't want to do it. So you have to keep in mind all these things. Sometimes what we are doing, we are putting these patches from the opposite side so that they are able to see those patches. They are seeing their favorite cartoon characters. So that is the ideal thing. If you see the option number C, patching on the right eye. So with the help of patching on the right eye, what you are going to do, I am covering the normal eye because it was the left eye that was showing a problem. So because left eye was showing a problem, there is a propensity of left eye going into the amblyopia. So what I am doing, I am covering the right eye so that I can stimulate the left eye to see and improving the amblyopia in this patient. So I hope you have understood why we have ignored and ruled out the other options. We cannot wait, we cannot go for the watchful expectancy. No point of taking the intraocular pressure at this time, and MRI is certainly not the next best step Alright, MRI we are doing in cases of the paralytic squint, and there also we are not doing it next, okay. There also you are first doing the examination, trying to rule out the things, and then in the further course you can go and advise the brain MRI. Okay, in case of any doubt, you can always ping me up on our social media platforms, on our Telegram groups, DBMCI Premier Telegram group, as well as the Facebook group, and do let me know how you are feeling and what is your feedback about these case scenarios. Thank you and happy ophthalmology.